Okay, so now I'm talking about gestational diabetes in the structure of a mnemonic I made called Dr Apsimo. So that's looking at definition, risk factor, etiology, pathophysiology, symptoms and signs, investigation, management, outcomes. So starting off, what's my definition of gestational diabetes is impaired glucose tolerance that develops during pregnancy. So now risk factors. I'll do a big R here. The big one is obesity. Also have low exercise, past history of having a big baby. I'll just write a big bub. Certain family history of diabetes. There's also things like ethnicities. So some ethnicities get it more commonly than others. So I think that's African Americans, Hispanics, people from Southeast Asia. Big one for Australia is Indigenous people, Indigenous Australians. Is a risk factor. So yeah, and you also have things like smoking, which is a risk factor for most things. So that's your risk factors. Now I think, how does that lead to the etiology, or the development of the disease? So first, I think the best way to understand this is think about a normal pregnancy, and then talk about how the risk factors affect this. One other risk factor that I forgot to mention, I'll mention quickly, is no definable. So a good proportion of people who get it don't have any of these things. They're risk factors, but people without any of these risk factors do get it. So it's worth remembering. So onto the etiology. So normal pregnancy, what happens? You have your pregnancy slash placental hormones. The big ones here are probably cortisol plus progesterone, but it's complicated, and there's others, but they're probably the big players. Now, what that does is it interferes with post-insulin receptor signaling pathways. What's that mean? Put simple, stuffs up your ability of your cell to be sensitive to insulin. So that causes a decrease in insulin tissue. So start again. So that causes a decrease in the tissue sensitivity to insulin. Yeah. Now, Now, so that's the first thing. So what happens then? This is compensated by an increase in insulin production by your beta cells in your pancreas. Yep. Now, what this leads to is, so sensitive to insulin make more insulin. Simple. So what this leads to then is a secure and correct. So it's compensated, not fully, but it is compensated. Correct. Secure, correct glucose supply to the growing fetus. Yep, cool. That's pretty simple. Hormones and complicated hormonal stuff interferes with your post-insulin receptor pathways. It causes a decrease in your tissue sensitivity to insulin, which is compensated by your beta cells. Alright, so how do you get gestational diabetes? So I will do this in red, and we'll relate. First, I'll relate obesity. Also, I'll just quickly put in here plus fat. So yeah, you put on fat, and that also interferes with insulin. So the obesity, what happens is obesity also interferes with the post-insulin receptor signaling pathways, causing a even greater decrease in that. Now, yeah, that's remembered. Now, exercise as well. Normally, exercise will increase tissue sensitivity. And so, doing exercise, when you exercise a muscle, it takes up more glucose. Yep. So, exercise also does that. It also leads to a decrease there. Right. Now, looking at past history of Big Bub. Well, how's that related? It could be related to obesity, exercise, family history, and ethnicity. To me, that signals a genetic link. So, what's there? What happens is that there can be single gene mutations that normally don't really matter, but they're up-regulated, or they come out in pregnancy. Yeah. Now, what this does probably affects a couple of things. It probably might make people a bit less sensitive in the first place, and it also might mean that their beta cells are not so great. Now, another thing to think about, no definable risk factor. How does that come into it? It's potential they might have some of these issues as well, that just haven't came out yet, because you can't really test that in the clinical environment. And I'll just do a question, just one of the mysteries. Smoking, I think I mentioned. Who knows? Smoking does all sorts of things to your hormones, so and it's worth stopping either way. All right. So, where was I? Obesity, low exercise, other things cause you to have even less sensitivity to insulin. Now, which means you're going to have even more blood glucose, than what you normally would, which puts more pressure on the beta cells to compensate. Now, coupled with maybe some sort of problem with the beta cells, they lose the ability to compensate enough. So, I'll just write high blood glucose, low insulin sensitivity, not well compensated by beta cells. So there are beta cells in the pancreas. Not well compensated by beta cells. And that leads us to the start of our pathophysiology. P. What happens now? Yep. Excessive blood glucose. This has two things. To mum. So that's going to have all the problems that, say, diabetes type 2 has. Increased atherogenicis, all that stuff. Peripheral neuropathy, high blood glucose, not good. So to mum, that's right, similar to DM2, and it also will increase your risk of DM2. So yeah, a bit complicated. I don't really want to go into mum too much. I want to talk about what happens to the fetus a bit more. So fetus, you have this high blood glucose. So I'm just going to write high BG. Now the high blood glucose in itself can lead to a acidosis hypoxia, which in turn can cause myocardial dysfunction. Now, I don't think this actually happens that much, due to modern medicine and all that, but it's very, very much worth knowing and mentioning. Now, what else does the high blood glucose do? So now blood glucose crosses the placenta, but insulin does not. So what happens? All this blood glucose crosses the placenta, and the fetus will produce increased insulin. So I'll talk about the effects of this. So with the increased insulin in a high blood glucose level, the first thing you're going to get is you're going to have excessive growth. So, large for gestational age, I'll change colours here. Now I'll talk a bit more about this when I talk about management, but that causes problems for mum, and you can also cause problems for bub. So and somehow, I don't think they really know, but some of the problems that it causes, I guess, is firstly, if you're large for the gestational age, it might be more likely to be born preterm because you're going to be too big otherwise, depending on how they manage the pregnancy. So increased preterm, decreased lung development when born, which is not a good thing. Now, there's something also that when a big bub tends to have a higher risk. So if you're born of later just of diabetes when they're an adult, or obesity, increased risk of obesity. What else does the excessive insulin production do? You can think, all the babies in this high blood glucose environment is producing all this insulin. So then once born, it has high insulin but low blood glucose. So it will very likely suffer from hypoglycemia at birth. And I'll talk about how that's fixed, which is pretty simple anyways. Alright, so that's the basic pathophysiology. So the next thing I want to talk about is signs and symptoms. SNS. Unfortunately, it is typically a symptomatic, I guess. Unfortunately for the diagnosis, I guess. There is sometimes some symptoms. You might have more thirst, nausea, urination, sometimes, very rarely, you also have fatigue. Rarely you might get some blurred vision. Rarely, I think when it's quite bad. But overall, it's asymptomatic. So, normally your investigations are prompted by your signs and symptoms in the history. In this case, it's not. So what we do need to do, what we use to prompt our investigations are the risk factors. So if we go back up here, obesity, low exercise, past history, past family history, certain ethnicities, and no definable risk factor. I'm going to underline that. So obesity is probably the big one, no definable risk factor. Now, because no definable risk factor is quite a large, is something that happens that people get when they don't have any risk factors, I personally think it's worth screening everybody. But in the very least, you want to screen people with past history, obesity, things like that. But so investigation, I think screen everybody. Now the main test is called the oral glucose tolerance test. Oral glucose tolerance test. Plus variations. So some of the variations are a bit easier for the mum to do and a bit cheaper as well. So, but I'll just talk about the oral glucose tolerance test quickly. So what happens? You fast, and then they give you a specific amount of glucose. So at fasting, if your blood glucose is greater than 5.3, it's not good. Maybe have gestational diabetes. If after an hour it's greater than 10, not good. After 2 hours, greater than 8.6, not good. And this is all in millimoles per liter. Yeah. And there's plasma tests as well, but this is oral glucose tolerance test. I think is the main way it's diagnosed, and then there's variants for screening that I won't bother talking about. So investigations. So you've been investigated, you've gotten the diagnosis of gestational diabetes. Now what? Well, the first thing is in your management will be diet and exercise. So diet plus exercise. No, I'll just step back a bit. The big goals of management is not weight reduction, but prevention of fasting and postprandial hypoglycemia. Postprandial meaning basically after eating. And it's also to reduce excessive amounts of glucose to the growing fetus. So when it comes to diet, what they do is balance calories with correct calories for correct calories for correct optimum, I think is a better term. Optimum for optimum weight gain, because you want to be gaining weight in pregnancy, basically. So the right diet, and they do this with your 3 meals, 3 snacks, and then they have you balancing your macros. So like carbs are normally should make up, I think, 40 to 50% of your diet. Protein, about 20%. Fat, 25%ish, around that range. And high fiber and complex carbs to reduce your chances of having a hyper episode. So exercise, gentle plus regular. So as you remember, exercise itself will upregulate how much insulin comes into your muscle cells and all that stuff. So it's really good. Diet, you want your complex carbs so you don't have a hyper. You also want to have enough food but not too much. All that. It's pretty simple. So the next stage, I guess, in management is sort of your obstetric management. How the pregnant woman's going to be giving birth. I'll do it in a new obstetric management. Now this is really complicated stuff, but I think the main things in relation to gestational diabetes is timing plus route of delivery. So with timing, ideally you want to be deliver at age. Now, is best. Now, what that does is that that's generally the best. That will reduce problems like fetal hypoxia due to poor lungs. So deliver at age is generally your goal. So 38 to develop the right age, 38 to 41 weeks. Now, sometimes you might go early because they're huge babies. So you might deliver early, but you should only be doing it if the lungs are good. If the babies, the fetus, infant's lungs are good. Now route cesarean, vaginal is preferred, and it can be inducted. Generally preferred, and it can be inducted only if lungs are good. Yep. But cesarean is good generally if it's very large. So if greater than 4,200 grams. So it's a really big baby, or depending on the mother's own preferences and what her pelvis is like and all that, will prompt you more towards cesarean. So the next part with management is your neonatal management. Neonatal. So that's really looking at looking after the complications of having gestational diabetes. So the big one, as I mentioned earlier, you're going to have high insulin. The baby has been producing a lot of insulin, but then they're suddenly not in that high glucose environment. So the high insulin can lead to a hypoglycemia. So we prevent that. We don't get to there, and we prevent that from happening with early feeding, and that's usually dextrose 10% in water. That's the basic thing. The other thing is, if they've been, especially if they've been born early, which generally isn't such a good thing, but to help their lungs out because they have their surfactant problem and all that, they normally do ventilation therapy plus administer surfactant. Yeah, that's the big part of it. And just talking about your sort of postnatal kind of stuff. You do all your monitoring and all that kind of all your normal things. But the special thing is for mum, monitor plus reduce risk factors for diabetes type 2, because having gestational diabetes puts you at a greater risk. So then it's time to aim to lose some weight in a healthy way. Beware certain contraceptions. And get your regular tests and that kind of stuff. So that's about it. Outcomes. It's quite. I don't think the outcomes are generally that bad. But I'll break it up in with well-controlled outcomes. I'll break them up into mum and bub, and well-controlled, poor-controlled. So with my notes on this, I got if it's well controlled, they have good quality of life. Not particularly high depression. And if it's well controlled, it might actually increase their general health. But they do have that increased risk of diabetes type 2. So that has to be monitored. But you know, if it is well controlled and well monitored afterwards, then they're going to be reducing their risk of diabetes type 2. Poorly controlled, you have an increased chance of cesarean, which has its own risks. It's right risky. I think it's probably a bit controversial. You also have a greater risk of birth trauma. I think that's the right term. So you know, if via birth trauma via vaginal, and you also have an increased risk for repeat gestational diabetes. They also have that great risk to an increase in diabetes type 2. I'm not sure if it's because of the shared risk factors or specifically because of the gestational diabetes. I think I had a bit of a look but really couldn't find much. Now, for bub, if it's well managed, just wait. I just remembered something I forgot quickly. In management, diet and exercise. Here, find some room here in red. If the diet and exercise doesn't work, the mothers can be given insulin. But the risk of insulin is, I'll just write, beware hypos. In the mother, the insulin resistance happens for a reason. You want that constant good supply of glucose to the baby. So if you're using insulin, you can have hypos. The baby doesn't get the nutrition they need. So beware hypos, as that can cause low birth weight and that kind of stuff. Similar, there is metformin. Now, my research, this is probably at quite a big level. My research showed that metformin used to be not looked at very well, but now the evidence shows that apparently it's not so bad, and it is permissible to give them to mothers if diet and exercise doesn't control their gestational diabetes. But that's something I would look up for myself. Alright, I'll just cover that and I'll quickly get back into bub so you can understand. So if it's well managed, statistically you have a greater risk for gestational age. That's especially big if they use insulin, because, well, the management means reducing diabetes. So, well, maybe with over management you have that, but anyways, small for gestational age. Otherwise, if it's well managed, it's good outcomes. So I'll just write good outcomes. And you have a 2 to 4 times decrease in metabolic complications compared to poorly managed. So for poorly managed, your hypoglycemia, macrosomia. You have a great risk of childhood plus adult obesity. You also have your worries of increase of respiratory distress, because in poorly controlled, you got the greater chance that you're going to have to induce labor or perform a cesarean early. Now, in pre-gestational diabetes, there's an increase in congenital abnormalities that's not shown in gestational diabetes. So I just want to mention that apparently it doesn't cause congenital abnormalities. Sorry. Yeah. So now another thing that's very important to, I guess, remember is that it increases your risk of stillbirth, and if the mother has ketoacidosis, I'll write that in here, ketoacidosis, that's 50% risk of increase. So normally it's an increase even without that, but if it's poorly managed. But if there's ketoacidosis involved, that's a 50% risk of stillbirth. So yeah, that's big. So I guess the point of this part is that well managed, the outcomes are quite good. Poorly managed is quite risky. So very much worth managing. Anyways, that's my overview. I'll leave it there. Yeah, cheers.